Hello dear students and the members of this fraternity of medicine and physiology. Today I have come with a topic which is not only important from physiological standpoint, but it's equally, if not more, important from clinical point of view as well. The topic is potassium homeostasis. How is potassium in the body regulated? How is potassium in the plasma, potassium levels of the plasma are regulated? What are the influencers which influence the levels of potassium in the plasma or in general the potassium in the body? So, before we start with this particular topic, let me take you to some of the basic facts. The basics, if you look at the intracellular fluid and the extracellular fluid, potassium is an intracellular cation, a major or the most important intracellular cation. 145 milliequivalents per liter, that's its level in the ICF, and in the ECF, outside the cells, its concentration is low, 4 milliequivalents per liter. So, the first point, potassium is intracellular. Major chunk or 90% of the potassium is located intracellularly, and the plasma levels are very low, 4 milliequivalents per liter. But mark this, even if it's even though the levels are very low, a minor deviation in the plasma potassium concentration results in clinical disorders. Why? We will see that in some time. One more point that I need to emphasize before we actually start discussing this. Let's also see the sodium. Sodium has got a high concentration in the ECF in the plasma and relatively low inside the cells. So, 141 milliequivalents per liter outside the cells or serum sodium, and intracellularly it's low, 14 milliequivalents per liter. So, the first point that I am trying to make here is sodium concentration gradient is from outside to inside of the cell, but potassium concentration gradient is from inside to outside of the cell. Another point that I need to emphasize in this particular diagram is that whenever sodium enters the cells, I am going to need this particular fact I will need and I will discuss later. Whenever sodium enters the cell, it is going to create an electrochemical gradient to drive the potassium out of the cell. You need to remember this fact. Whenever sodium comes into the cell, it will create an electrochemical gradient to drive the potassium out of the cell. Look, already concentration gradient for potassium is favoring potassium to go from inside to outside. On the top of that, if the sodium comes in for whatever reason, for example, during the depolarization of cells, sodium coming in brings in lot of positive charges into the cell, and therefore potassium, being the positive charge, is driven out of the cell because of that electrochemical gradient which has been altered or created by the sodium influx into the cell. Remember this, I will discuss this later again in the particular context. The second point we need to understand is and I have said this a number of times in my lectures, almost all the physiological mechanisms in the body, they depend on the functioning of the sodium-potassium pump. So, even here, sodium-potassium pump is going to be the major influencer for the potassium levels in the plasma. If you look at the activity of the sodium-potassium pump, what it does is it binds the potassium from outside the cell and brings that potassium into the cell. So, 2 potassium ions are brought from outside to inside, and of course 3 sodium ions are taken from inside to outside. That's the activity of the sodium-potassium pump. The point that I am trying to make here is anything that influences the activity of the sodium-potassium pump will also have the influence on plasma potassium levels, because potassium is being brought from outside to inside of the cell. So, anything that influences this activity is going to disturb or is going to alter the levels of potassium in the plasma or intracellular potassium as well. In fact, I reiterate again, even during this discussion, a number of times I am going to say, finally it boils down to one thing: the functioning of the sodium-potassium pump. Everything boils down to the sodium-potassium pump and its activity. So, with that in mind, now let's have a look at the potassium homeostasis, the topic at hand. First point, why do we need to regulate the potassium in the body? Potassium is the most abundant cation in the ICF, as I mentioned just now. Plasma potassium level is very low, 4 milliequivalents per liter, and it needs to be tightly regulated. The second point, why do we need this regulation of potassium is, these are the important functional implications of potassium. Number one, potassium is osmotically active and it's going to determine the volume of the ICF compartment. I mentioned just now that potassium is the major cation in the ICF and it's also osmotically active. Maybe not as much as sodium, but it is active osmotically, and therefore potassium determines the volume of the ICF compartment as a whole, just as sodium determines the volume of the ECF compartment. You know, sodium is more in the ECF, and blood volume, ECF volume, that compartment is determined by the sodium levels. Potassium determines the volume of the ICF compartment. Second point, I am just trying to enumerate the reasons why we need to regulate the potassium in the body. Second, potassium is the major determinant of the membrane potentials. You know, all cells, their resting membrane potentials are because of the potassium's diffusion potential from inside to outside. All the cells are negatively charged on the inside, their membranes, and it's called as RMP, and it's mainly because of the potassium's diffusion potential. So, RMP and excitability of the excitable cells. You know, nerve and muscle are the excitable cells, and potassium is going to diffuse out and repolarize those cells after they excite. So, anything that alters the plasma potassium is going to alter this activity of repolarization, and if that is affected, then the further excitability of the cell itself is affected. In fact, cardiac muscle cells, if the potassium gets either increased or decreased, either ways it is going to possibly lead to cardiac arrhythmias. So potassium disturbance in the plasma may lead to cardiac arrhythmias, the excitable cell that cardiac cell is. Another reason why we need to regulate the potassium is that potassium balance is reciprocally involved with acid-base balance. We will see how later on, but it is reciprocally connected with the acid-base balance. I mean to say that if there is acid-base disturbance, it will disturb the plasma potassium levels, and if the plasma potassium levels are disturbed, it may disturb the acid-base status of the body fluids. So reciprocally involved, Another reason why we need to regulate the potassium is it also affects the metabolism. Some of the enzymes involved in carbohydrate metabolism or electron transport, they depend on the levels of intracellular potassium. So all in all, it's very important that we tightly regulate the potassium levels in the plasma, in the ECF, and as a whole inside the body. So let's see how it's achieved. So I'm going to make two parts of this discussion. First, we have seen why we need to regulate the potassium levels in the body. Now the two parts that I'll discuss, one is how do we regulate, how is the body regulating the plasma potassium levels, and the second part will be how is it that the body regulates the whole body potassium levels. Okay, now before we start with that, let's just have a summary. Distribution of potassium and then the factors influencing this distribution. Of the total body potassium, 90% is in the ICF, intracellular fluid. We saw that already. 8% is in the bones and connective tissue. 2% is in the functional ECF. So only 2% of the body's potassium is in the ECF. And remember, 4 milliequivalent per liter, the plasma potassium levels. But if it goes below 3.5 milliequivalents per liter, we would call it hypokalemia, reduced potassium in the serum or in the plasma. And if it goes above 5 milliequivalents per liter, we would call it hyperkalemia, increased potassium in the plasma. Right. And as I mentioned, there are two types of mechanisms. One, the mechanisms that regulate ECF potassium, and two, the mechanisms that maintain the body's potassium constant by adjusting the renal potassium excretion with the dietary intake of potassium. So dietary intake and renal excretion are balanced by the body in order to adjust the or maintain the body's potassium levels as a whole. Right, so let's see the first one, mechanisms that regulate ECF potassium concentration. Well, the most important physiological influencers are insulin, epinephrine, aldosterone. Remember them? These three are the most important physiological influencers of the ECF potassium. Insulin, epinephrine, aldosterone. All three of them, they increase the potassium uptake by the cells, especially the skeletal muscle, liver, bone and RBCs. Skeletal muscle, liver, bone and the RBCs. In these cells, the uptake of potassium will be enhanced, increased by these three hormones, insulin, epinephrine, aldosterone. And as I mentioned previously, how do they achieve this? By stimulating the sodium potassium pump. We've already seen this. Sodium potassium pump brings the potassium from outside the cell or from the blood into the cell. So it will push the potassium into the cell. From plasma, into the cell, potassium will be pushed as we've seen previously, and therefore that is how they will influence the potassium levels. So sodium potassium pump is the major influencer of the ECF potassium concentration, and therefore the conditions that alter the functioning of the sodium potassium pump would therefore alter the serum potassium levels. So if something that influences the sodium potassium pump, as we mentioned, these are the potassium ions, they are taken from the plasma, from the blood vessel, and they are pushed into the cells and sodium is thrown out. So anything that disturbs this will cause potassium to rise in the bloodstream. Okay, and insulin, epinephrine, aldosterone, they are going to increase the activity of this pump and they will push the potassium into the cells. What are the conditions that influence the activity of sodium potassium pump? Hypoxia, a major influencer, because no oxygen, no ATP generation, and if there is no ATP generation, this sodium potassium pump is an ATPase. No ATP, no functioning of the sodium potassium pump. What is the result? Potassium cannot be pushed into the cells. Potassium levels will rise in the plasma. So, digitalis, cardiac glycosides. You know, digitalis binds with the sodium potassium pump and it inhibits the functioning of the sodium potassium pump. So, one side effect of the digitalis is that it causes hyperkalemia. Potassium levels will rise in the plasma, or in other words, hypokalemia potentiates the digitalis toxicity. Remember, potassium and digitalis, they are competing for the binding sites on the sodium potassium pump. So, if there is hypokalemia, if there is no potassium, then there will be digitalis toxicity because there will be low potassium. So, potassium is not able to compete with digitalis on these binding sites, and therefore, or in digitalis toxicity, one would administer potassium. Potassium will be administered so that potassium creates the competition for the binding site on the sodium potassium pump. Competition with digitalis. Right. So, sodium potassium pump, as I mentioned, and the conditions that influence the activity of sodium potassium pump, they will result in hyperkalemia. So, hypoxia, digitalis, they will result in hyperkalemia, increased potassium levels. pH of the extracellular fluid, another important regulator or influencer. Look, if there is acidosis, H plus levels rise in the ECF. What is the result? Now, this H plus will be pushed into the cells and potassium will come out of the cells to maintain electroneutrality. Let's just see here. The cells, they also have the H plus K plus ATPase. H plus K plus ATPase. And therefore, this pump is going to send the hydrogen ion and potassium ion in the opposite directions. So, let's say if there is acidosis, H plus levels or H plus concentration has increased in the plasma, then H plus will be pushed into the cells, and to maintain the electroneutrality, K plus will come out of the cells, potassium will come out of the cell, resulting in hyperkalemia. So, remember that would be the result of an acid base disturbance on the potassium levels. Right. So, if the H plus increases in the ECF, H plus will be exchanged with the intracellular potassium. That is, H plus goes in and potassium comes out. Well, this can be used in the emergency treatment of hyperkalemia. Please remember this. In the emergency treatment of hyperkalemia, this particular aspect can be made use of. How? We will infuse intravenous sodium bicarbonate. Now what happens is H plus, because now you have infused sodium bicarbonate in the intravenously, to neutralize it, the hydrogen ion will come out of the cell and potassium will go into the cell. I repeat once again, if there is hyperkalemia, we can make use of this activity of H plus K plus ATPase pump. Sodium bicarbonate is given intravenously. It comes into the bloodstream. Now this is an alkali. So to neutralize it, H plus from inside the cell will come out and the potassium, remember I said hyperkalemia, excess potassium in the plasma, that excess potassium will be pushed into the cell. So we can make use of this property of H plus K plus being exchanged by the don't get wrong information by the word exchanged. I don't mean exchange here. They are moving in the opposite direction. It's the pump that is causing H plus and K plus to go in the opposite directions. It's not an exchanger, mind you. Right. So that's one more point. Then insulin. Insulin promotes, now this is very important. You must always remember, insulin promotes glucose uptake by the cells and it promotes potassium uptake by the cells. Glucose and potassium, they are taken up by the cells under the influence of insulin. Particularly potassium uptake by the liver cells and skeletal muscle cells. And again, mechanism same, stimulation of the sodium potassium pump. So again, in hyperkalemia, increased potassium in the plasma, we can make use of this property. Give insulin and that insulin will push the potassium into the cells. From plasma, it will be pushed into the cells. So insulin is given. But remember, don't only just give insulin, you need to also give glucose along with it. Otherwise, it might cause serious hypoglycemia if you just give insulin. So insulin and glucose are given if there is hyperkalemia, increased potassium levels in the plasma. That potassium will be pushed into the cells by the insulin. How? Increased activity of sodium potassium pump. The next factor, epinephrine. Now this, acting via beta 2 receptors, epinephrine increases the potassium uptake by the cells. Again, mechanism same, stimulating the sodium potassium pump activity, potassium is pushed into the cells. Of course, stimulation of the alpha receptors has the opposite effect. It releases potassium from the cells into the blood. So remember, there is this opposite effects of beta 2 receptors versus alpha receptors action of epinephrine. But we are more focused right now on the beta 2 receptor action of epinephrine. When it acts via beta 2, potassium is taken up by the cells. Increased activity of sodium potassium pump. Potassium pushed into the cells. The point that you should note here, clinically very important point, is that suppose the person is on beta blockers. Propranolol is a beta blocking drug and it is blocking the action of epinephrine on these beta receptors. It's given in hypertension. Now what will happen is, there will be a rise in plasma potassium after potassium rich meal. Well, that's normal. When you ingest a potassium rich meal, the potassium in the plasma is going to rise. That's expected. But If the person is on propranolol, which is a beta blocker, the action of epinephrine will not happen to push the potassium into the cell rapidly, and therefore there would be a dangerous rise in the plasma potassium levels. You get that point? Potassium ingested and after the meals, therefore plasma potassiums are anyways going to rise. That's normal. But then that potassium is immediately pushed into the cells. Normally, it's pushed into the cells. But the person taking beta blocker, this pushing of potassium into the cells will not happen because there will be no epinephrine action on beta 2 receptors to push the potassium into the cells, and therefore there would be a dangerous rise of potassium in the plasma after the meals. So I made one point here is that when we ingest the potassium in the diet, it goes into the plasma, it's absorbed into the bloodstream, and then it has to be tightly regulated, mind you. So immediately it is pushed into the cells. There is one more way of handling this potassium, that is excretion by the kidneys. Potassium can be excreted out of the body, but that takes a long time. So immediate action is the moment potassium starts rising in the plasma, it is pushed into the cells. Kidneys will act later. Right, one more point, plasma osmolality. Remember, we are discussing the influencing factors that alter the plasma potassium levels or ECF potassium levels. What we have discussed so far, I told you at the start, insulin, epinephrine, aldosterone, three most important physiological influencers. We have seen the effect of insulin, we have seen the effect of epinephrine. Aldosterone I am going to reserve for the discussion along with the kidney. So right now we have discussed these two, plus pH of the extracellular fluid we discussed, then sodium potassium pump of course. Plasma osmolality. Look, now if there is hyperosmolality, what will happen? If the plasma osmolality increases, here is a cell and here is a blood vessel, and the plasma becomes hyperosmolar. So if there is hyperosmolar plasma, as a result of that, naturally the fluid, water will come out of the cells into the plasma. It will be pulled, water will be pulled out of the cells into the plasma, into the blood vessels by osmosis, because the plasma is hyperosmolar. What will be the result? Because the water inside the cells has reduced, water has come out. So since water has reduced inside the cells, the potassium concentration rises inside the cells. It's a relative concentration because the water has gone out, cells have dried up little bit, and therefore potassium concentration inside the cell increases. Potassium will become more concentrated because water has left. And since potassium becomes more concentrated inside the cells, now it becomes even more favorable for the potassium to come out of the cells, resulting in hyperkalemia. So remember, if there is hyperosmolarity of the plasma, the result is potassium will come out of the cells into the plasma, into the blood, resulting in hyperkalemia. I told you the reason. The cells will dry up because water has come out due to the hyperosmolarity, and therefore the potassium concentration will rise inside the cells, and therefore that potassium will come out because of that favoring concentration gradient from inside to outside. One more factor, tissue trauma. If there is injury to the cells, we have already said this, that potassium is mainly an intracellular cation. Most of the potassium is inside the cells. So if there is a tissue trauma, if there is cellular lysis, then that potassium inside the which is there in the cells will come out, and it will come out into the ECF and it will cause hyperkalemia. Please remember, injury to the cells, hemolysis, severe exercise, potassium from the skeletal muscle cells will come out, resulting in hyperkalemia. I would just introduce one more term to you, and that's pseudo hyperkalemia. Since we are talking about injury to the cells or hemolysis, let me just add one more term here, pseudo hyperkalemia, a pseudo rise in potassium in the serum. Why am I calling it pseudo rise? Look, suppose during the collection of blood sample, I'm just giving the example of this pseudo hyperkalemia. The cell injury is not real. It's not because of some inflammation or some rhabdomyolysis or a genuine cause. It's just that while you are withdrawing the blood from a patient, that handling of blood and blood sample may cause injury to the RBCs. Yes, that happens sometimes. And this mishandling of the stored blood or during withdrawal of the blood from the patient, there is injury to the red cells, RBCs, and it's called as artifactual rise in the plasma potassium. Artifactual, it's not real actually, there is no real injury to the cells because of some pathophysiology happening. It's just that mishandled blood sample has caused trauma to the RBCs, and such a condition is called as pseudo hyperkalemia. So these were the mechanisms for potassium balancing of potassium in the ECF potassium. So how potassium is balanced between extracellular fluid and cells, intracellular fluid, or plasma potassium and ICF potassium. That was the first part. Now let us go to the second part, and that is maintaining the potassium balance of the body as a whole. So, I have already mentioned the first important point in that. How does the body regulate the whole body's potassium? We are not only now looking at the ECF versus ICF potassium or just the plasma potassium. We are talking of the whole body potassium. How is that balance maintained or a level maintained? I mentioned it already. Renal handling of potassium is balanced with the dietary intake of potassium. So you see, we ingest about 100 milliequivalents of potassium per day in the diet, or thereabouts. It depends on how much potassium is there in the diet. There are some potassium rich foods, banana, coffee, tomato, some of the potassium rich foods. Even in the ORS, oral rehydration solution, the addition of lime is for the potassium, to add the potassium. So we ingest this potassium in the meals. From the GIT, it will be absorbed into the blood and it will go to the cells. It will be entering the cells. So from the GI tract, the potassium is absorbed, it has gone into the ECF or into the plasma, and it will go to the cells. I mentioned already that about 8% of the body's potassium is in the bones or in the connective tissues. So it will go to the cells, and then remaining will be excreted by the kidneys. It's going for the potassium pool of the body. So We have already discussed this. Potassium in the plasma should not rise beyond 5 milliequivalents per liter. That will be dangerous. It can cause cardiac arrhythmias, it can cause various other things. And therefore, there are two ways of curtailing this. Dangerous rise of potassium in the plasma can be avoided by two things. One is that it immediately pushed into the cells, and we have seen those factors which push the potassium into the cells. And the other one is excreted by the kidneys, excreted via kidneys. Well, kidneys will take about 5 to 6 hours to excrete the potassium. Look, they are going to take a long time to handle this potassium which was taken in the diet, in the meals. So, there is a possibility of dangerous rise, and therefore, this mechanism where potassium comes into the plasma and immediately pushed into the cells becomes a very, very important mechanism to prevent dangerous rise of potassium in the plasma. But the point is, via foods, about 100 milliequivalents per day is the potassium intake. Absorbed from the small intestine, it enters the ECF, enters the plasma, it would cause a dangerous rise in the plasma potassium levels. So, such a rise is prevented by the rapid uptake of potassium into the cells and excretion by the kidneys, the second mechanism. And excretion via kidneys would require about 6 hours. So, it's a very slow process. Now, coming to the next point, this we have already mentioned. So, coming to the next point is, there are three routes for potassium excretion: urine, feces and sweat. Three important routes or three routes for potassium excretion: urine via kidneys, then feces and sweat. Normally about 90 milliequivalents per day is excreted by the kidneys. We have consumed 100 milliequivalents per day. Out of that, 90% or 90 milliequivalents are excreted by the kidneys, and just about 10 milliequivalents per day is excreted into the feces. Right. And some of it is also in the sweating. Of course, this proportion will, this amount can slightly change. For example, if there is diarrhea, then there is excessive loss of potassium into the stools, into the feces. Or if there is excessive sweating, then look, normally potassium loss in the sweating is negligible. But if there is excessive sweating, then the potassium loss can be a major amount via sweat. With that in mind, let us see the role of kidney in the potassium balance. Very, very, very important role. As I mentioned already, stools, the feces and the sweat, their fraction of potassium loss is constant. Whatever potassium intake is there, I mean, even if your potassium intake rises by 5-fold, the skin and the stools, feces, GIT will excrete only a constant fraction of potassium from that. So, kidneys will have to handle that 5-fold higher potassium which has come into the plasma. Remember, that's why kidney role is very important. Only about 10% is going to be lost in the feces and sweat. So, if it's a 5-fold rise, kidneys will have to deal with that 5-fold rise in the plasma because of the dietary intake has increased. Right. So, very important role played by the kidney. Now, just interesting fact, how kidneys handle potassium. You know, a very interesting fact I would like to mention here is that potassium is one such substance or ion on which all four processes of the kidney take place. What are those four processes I am talking about? Glomerular filtration, then reabsorption by the tubules, then secretion into the tubules, and also excretion into the urine. All four processes: filtration, reabsorption, secretion, and even excretion. So potassium, I think the only other substance on which all these four processes can occur is urea. Urea is, the tubular cells are highly permeable to urea, and therefore all four processes occur. But of course, urea is finally to be excreted. Potassium is needed by the body, so it can be reabsorbed, or if it is increasing in the plasma, it has to be excreted out. So it will be secreted. So remember, point I am making is, normally sodium, for example, it's always reabsorbed from everywhere. Sodium is needed and therefore is needed by the body, needed into the ECF. So it will always be reabsorbed from anywhere. Sodium is never secreted anywhere. What about the potassium? Potassium can be reabsorbed, potassium can be secreted, depending on the requirement. If there is a hypokalemia, less potassium, then tubules will reabsorb potassium, and if there is a hyperkalemia, potassium needs to be eliminated out of the body, then tubules will secrete potassium and it will be eliminated out. So that's why kidney's role is very, very critical in this. Now let me just quickly go through this part. 65 to 70% of the filtered potassium is reabsorbed from the PCT. Almost whatever amount filtered. And remember, if potassium levels have increased in the plasma, then filtration of the potassium at the glomerulus will also increase. Whatever amount got filtered, 2/3 of it, 67%, 70% almost, is reabsorbed from the PCT. So major reabsorption occurs in the PCT. About 20% is reabsorbed from the loop of Henle, and then so remember, these two segments, PCT and the loop of Henle, they reabsorb a constant fraction of potassium. Constant fraction. I mean to say, if your potassium intake has increased 5 times and plasma potassium has increased tremendously, then filtration of potassium at the glomerulus will also increase, and therefore reabsorption of the potassium from the PCT will also increase. Remember this. So the main part of the nephron is the distal tubule and the collecting duct. Collecting duct is the major part which is going to decide what to do with the potassium eventually, because it can either reabsorb or it can secrete potassium. Look, so far we saw the various parts of the nephron, they were reabsorbing the potassium. Collecting duct can reabsorb or secrete potassium depending on what is the body's potassium status, what is the level of potassium in the ECF. So if there is increased intake of potassium, for example, if the intake in the diet has increased, then that means there will be increased potassium in the ECF. So more potassium filtered at the glomerulus. Also, there will be increased potassium secretion by the collecting duct. Collecting duct will secrete more potassium and potassium will be excreted into the urine. Remember, so collecting duct is the place which will finally decide. Let's see how is this potassium secretion by the collecting duct is regulated. First of all, let's see what happens at the collecting duct. Then we have a fair idea about how it handles further. The collecting duct basically has it is lined with two types of cells. The two types of cells that line the collecting duct are principal cell or P cell and intercalated cell or I cell. So, principal cell and intercalated cell. So far as the principal cell is concerned, it reabsorbs sodium and secretes potassium. It reabsorbs sodium. I am talking about the principal cell, P cell. It reabsorbs sodium and secretes potassium. I will mention how it happens. And then intercalated cell, it reabsorbs this potassium and secretes H+. It reabsorbs the potassium and secretes the H+. So, that's one basic point that you need to understand. Now, this collecting duct and the principal cell, how does it achieve this reabsorption of sodium? Let's draw it again. Here is a collecting duct, here is the principal cell, and next is the intercalated cell. This is just a diagrammatic representation. I am showing them side by side just to make a point. So, here is the P cell, principal cell, and here is the blood vessel, and this is the lumen of the tubule. So, the principal cell has two sides, as you know. The side that faces the lumen is called as the apical membrane. This apical membrane has the channel called as ENaC, epithelial sodium channel, ENaC. So, sodium from the tubular fluids will diffuse into the principal cell, and then on the basolateral membrane, look, the membrane that is facing the blood vessel is called as the basolateral membrane of this principal cell. Here there is sodium potassium pump. I have already mentioned a number of times that everything boils down to the sodium potassium pump. So, sodium from the tubular fluids is diffusing into the cell, principal cell, and then through the apical membrane, and on the other side, that is basolateral membrane, there is sodium potassium pump. So, sodium is removed from inside the cell and it will enter the blood vessel. In fact, let me tell you, it's other way around. Sodium potassium pump first removes the sodium from inside this cell. So, sodium goes into the blood. So, sodium concentration inside the cell will fall because sodium has been pumped out of the cell. And because the sodium concentration falls, therefore, then sodium can go from high concentration to low concentration. High concentration in the tubular fluids, low concentration inside the cell. Why low concentration inside the cell? Because sodium potassium pump has already driven the sodium, pumped the sodium out of the cell. This is how, in a two-step process, sodium potassium pump and the ENaC, epithelial sodium channel, will remove the sodium, reabsorb the sodium. Now, I have already mentioned this, that when sodium enters the cell, sodium being positively charged ion, and positive charges entering the cell. Remember, we mentioned this at the start of the lecture. Sodium entering the cell means positive charges have come in, and therefore then that creates the electrochemical gradient for the potassium to be driven out via apical membrane, via the diffusion channels for potassium. Potassium will diffuse from inside the cell. Look, already sodium potassium pump here had brought the potassium into the cell. Remember, sodium was taken out of the cell, potassium from the blood was taken inside the cell, pumped into the principal cell. Now this potassium will simply diffuse via the apical membrane facing the lumen. Why potassium diffused out of the cell? Because sodium has diffused in. Positive charges have come in and that has created the electrochemical driving force. More positive charges inside the cell, so the positive charge, that is potassium, will go out. It will be driven out of the cell. It diffuses out and it comes into the tubular fluids. That is how potassium is secreted by the principal cell. And then of course I mentioned intercalated cell, which can reabsorb the potassium and secrete the H+. We have seen that also, the potassium and hydrogen, they go in the opposite directions. So now let's see what are the physiological regulators of potassium secretion by the collecting duct. We saw so far how the potassium is secreted into the collecting duct, into the tubular fluids by the principal cell. Now let's see what are the regulators of this. Most important ones, I will mention 2 or 3. Plasma potassium levels, aldosterone, and rate of flow of tubular fluids. These 3 are the most important one. Plasma potassium levels, aldosterone, which we had already mentioned that I'll discuss aldosterone with the kidney function, and rate of flow of tubular fluid. So let's quickly see these functions. First, hyperkalemia. How will it influence the secretion of potassium into the collecting duct, which we saw just now? If there is hyperkalemia, excess potassium in the plasma, then suppose there was high dietary intake of potassium, increased plasma potassium levels have happened, so hyperkalemia has happened. This will stimulate the sodium potassium pump in the basolateral membrane. Remember, we have already seen this is a principal cell, P cell, and in the basolateral membrane there is sodium potassium pump. It causes what? It causes potassium from outside, from the blood vessel to come into the cell. Potassium is pushed into the cell. So hyperkalemia, suppose there is excess potassium in the plasma itself, in the blood, this will stimulate the activity of sodium potassium pump in the basolateral membrane. Here is a tubular lumen, right? So increased activity of sodium potassium pump means what? Potassium from the blood has been pushed into the principal cell, P cell, and then on the other hand, because the activity of sodium potassium pump has increased, sodium from the lumen is entering via ENaC, epithelial sodium channel, creating the electrochemical driving force. I mentioned it already, because of which the potassium which has come into the cell from the blood will be pushed into the lumen and will be excreted into the urine. So remember, hyperkalemia does 2 things. It increases the activity of sodium potassium pump. This is the sodium potassium pump. Activity increased. That means more potassium coming into the principal cell, and plus because sodium is coming in more from the lumen, from the tubular fluids, electrochemical driving force for potassium from the cell to be secreted, to diffuse out of the cell, coming into the lumen, into the tubular fluids. So potassium got secreted in increased amount, potassium is excreted out. So remember, hyperkalemia, excess potassium in the plasma, potassium has been secreted more and excreted, lost into the urine. Right. Another one. Next, very important factor which I had kept for the discussion in the later part, aldosterone. It stimulates potassium secretion. Suppose there is hyperkalemia, it is going to we will need to excrete the excess potassium, right, into the urine. We saw one mechanism. Now let us see aldosterone. Aldosterone will remove potassium from the plasma and excrete it into the urine. Aldosterone reabsorbs sodium, we know that, and it excretes potassium. Potassium is excreted into the urine. How? There are various mechanisms. For example, increases the number of sodium-potassium pump in the basolateral membrane. It increases the number of sodium-potassium pump. Here is a sodium-potassium pump. Its number is increased. So, more potassium will be taken from the plasma. It will enter the principal cell and more potassium will diffuse out into the tubular fluids and more potassium excreted. That's one mechanism. The other mechanism, increasing the expression of ENaC, epithelial sodium channel, in the apical membrane. Yeah, right. This apical membrane has ENaC. ENaC is epithelial sodium channel. Now, if those numbers increase, what will happen? More and more sodium will come in for the reabsorption from the tubular fluids, from the lumen into the principal cell. More sodium coming in means what? More electrochemical driving force. More positive charges have entered the cell. So, more driving force for potassium to be driven out of the cell. Already potassium has come in from the plasma. It has entered this lining cell, the principal cell. Now, it will be further pushed into the tubular fluids, into the lumen, and potassium more secreted, potassium more excreted as well. So, increased expression of ENaC. Very important fact about aldosterone. It not only reabsorbs sodium, it also secretes potassium by increasing the expression of ENaC. Remember this. Okay. Then aldosterone also elevates two more things. I need to mention them here. Aldosterone also increases the expression of SGK1. SG, or rather, I beg your pardon, serum glucocorticoid stimulated kinase. Serum glucocorticoid stimulated kinase, that's SGK. Now, its expression is increased by aldosterone. Serum glucocorticoid stimulated kinase, its expression is increased. What is the effect of this stimulated SGK? It increases the expression of ENaC in the apical membrane of principal cells. Again, the effect is via ENaC. So, more and more sodium will be reabsorbed. That creates the driving force for the potassium to be secreted by the cell. Then, another action of aldosterone, we saw it increases the number of sodium-potassium pump, 1. We saw it increases the expression of ENaC in the apical membrane. Then it increases the expression of SGK1, which further increases the ENaCs in the apical membrane. It also stimulates CAP1. CAP1, that is channel activating protease. Channel activating protease. CAP1 is channel activating protease. Aldosterone increases or stimulates the expression of CAP1. Even that has the similar action. Increased expression of ENaC in the apical membrane of the principal cell. So, increased reabsorption of sodium. And then in some way it also stimulates the fifth action I am mentioning for aldosterone. First one, increases sodium potassium pump activity on the basolateral side of the principal cell. Then second one was increased expression of ENaC, so that sodium reabsorption increases through ENaC and that drives the potassium out. Then third, it increases serum glucocorticoid stimulated kinase, which increases the expression of ENaC in the apical membrane of the principal cell. It also stimulates CAP1, channel activating protease, that also increases ENaC. And final action is it increases the permeability of potassium, permeability of the membrane, permeability of the apical membrane for potassium diffusion. So potassium from inside this principal cell will move out of the cell and it will come into the tubular fluids. So potassium secretion will increase and potassium excretion will increase. So 5 actions of aldosterone, very important physiological role there. Now next, and we have already mentioned this, that what is the or the next factor is the rate of flow of tubular fluids. The rate of flow of tubular fluids. Important factor that determines the potassium excretion. Remember, increased flow of tubular fluids will have tremendous role to play in potassium levels in the plasma. So let's understand this. If there is increased flow of tubular fluids, first of all, when would that happen? For example, it may occur with diuretics. You know, diuretics, they increase the flow of tubular fluids. Diuretics are the drugs that increase the urine output, increase water excretion, increase urinary output. So they increase the flow of tubular fluids. Volume of tubular fluids has increased, flow of tubular fluid, rate of flow of tubular fluids has increased. Or suppose there is increased ECF volume. This increases the rate of flow of tubular fluids. Now, how does it affect the potassium excretion? Let's try to understand that, very important one. Here is a collecting duct and these are the cells lining the collecting duct. Now imagine that there is a tubular fluid that is flowing down the tubules. This principal cell has in its apical membrane facing the lumen, in its apical membrane has the certain cilia. Now what happens is, if the flow of tubular fluids increases, more rate of flow of tubular fluids are flowing rapidly, they tend to bend these cilia in the apical membrane of the principal cell in the collecting duct. Bending of the cilia is known to increase a calcium channel, also called as PKD1, PKD2 calcium channel complex. PKD1, PKD2 calcium channel complex that gets activated because of the bending of these cilia. Remember why the cilia have got bent in the apical membrane? Because the rate of flow of tubular fluids has increased. Tubular fluids are flowing rapidly because of diuretics or because of increased ECF volume. Now, because of this bending of the cilia, this calcium channel called as PKD1, PKD2 calcium channel complex is activated. What will be the result of that? Calcium channel activated means calcium will enter the cell, and remember cations are entering. So what happens is lumen becomes negative, inside of the cell becomes positive, and this also increases the potassium permeability to the apical membrane. I mean, more and more potassium will be driven out of the cell into the lumen, into the tubular fluids, and more potassium can be excreted into the urine. So remember, more the rate of flow of tubular fluids, if they are flowing rapidly, that also can increase the potassium excretion by this mechanism. Please remember this, the cilia, they are bending more because of the faster rate of tubular fluids, and that activates the calcium channel. Calcium enters and that increases the permeability of the apical membrane for the potassium. So potassium goes from the cell into the tubular fluid and potassium will be lost into the urine. So very important mechanism That's how diuretics result in hypokalemia, increased loss of potassium. The mechanism is very obvious. Diuretics, I mean, imagine this. Let's understand the mechanism of diuretics. Here is a loop of Henle. Here is a thick ascending limb of loop of Henle. Now, this thick ascending limb of loop of Henle, and then this is a distal part of the nephron. This is the collecting duct. It has this thick ascending limb has a transporter called as NKCC transporter, sodium potassium chloride co-transporter. It reabsorbs sodium, potassium and chloride. Okay. Now there is a diuretic called as furosemide or furosemide, commonly called as Lasix. It inhibits this NKCC transporter in the thick ascending limb of loop of Henle. What will be the result? Sodium could not be reabsorbed. Sodium potassium could not be reabsorbed. So sodium comes into the distal nephron, and you know, wherever there is sodium, water follows. So therefore, more sodium, more water. And if more sodium and more water, that means the rate of flow of tubular fluids. I mean, there is increased amount of water in this tubular fluid. So more and more tubular fluid, more and more rate of flow of tubular fluid reaching the collecting duct. And in the collecting duct, we already saw the mechanism that there are these cilia which will bend more and more. So calcium channel will open, calcium will enter the cell. In the principal cell, more calcium enters. That means potassium channels are activated, potassium secreted more and more by the principal cell, potassium lost out. So remember, electrolyte disturbances are caused by these loop diuretics, or most of the many diuretic categories like this. This is the mechanism of action. Or in the DCT, there is another transporter called as NCC, sodium chloride co-transporter over here. This is acted upon by another category of diuretics called as thiazide diuretics. So this sodium and chloride reabsorption is prevented in the DCT by thiazide diuretics. What is the result? Result is the same as I mentioned. Sodium and chloride could not be reabsorbed because this transporter has been inhibited. So more sodium in the tubular fluids, that means more water in the tubular fluids. More sodium and water means tubular fluids, their volume is more, the rate of flow of tubular fluids is greater, they are moving faster, bulkiness in the tubular fluids. So bending of the cilia, and the mechanism we have already mentioned. Therefore, these diuretics are known to result in hypokalemia. They cause loss of potassium out of the body, so reduced potassium levels. Now to prevent this, potassium-sparing diuretics came. Where do they act? Potassium-sparing diuretics, they will spare the potassium. They will not allow the potassium to be excreted excessively into the urine. They will not cause hypokalemia. So where do they act? They act on this ENaC. In the collecting duct, we have seen there is epithelial sodium channel, ENaC. Now this ENaC causes sodium reabsorption, and therefore that creates a transepithelial electrical gradient. That is, lumen becomes more negative because sodium has come into the cell, and cell itself becomes more positive because sodium has come in, and this drives the potassium from inside the cell into the tubular fluids, and this drives the potassium into the urine. We have seen this mechanism already. Now, these potassium-sparing diuretics, spironolactone or amyloride, they act on these ENaCs. Therefore, these channels are also called as amyloride sensitive channels. Spironolactone or amyloride are the potassium-sparing diuretics, for which reason they are also called as these channels are also called as amyloride sensitive channels. So how do these potassium sparing diuretics work? They block the ENaC. They block the action of ENaC. What is going to happen? Sodium will not be able to enter the cell. And if the sodium does not enter the cell, it will not create that trans-epithelial electrical gradient or the electrical potential difference from lumen into the cell. That difference will not be generated. And if that does not happen, potassium will not be secreted from the principal cell. And that does not happen, that means potassium will not be lost out into the urine, which we have seen happening with other diuretics. So that is how potassium will be spared. It will not be secreted much and it will not be excreted out much into the urine. But then, what is the, look, this cell is normally supposed to secrete and excrete the potassium, even normally. If that gets blocked by the amyloride sensitive, amyloride or potassium sparing diuretics, if they do not allow this potassium secretion even in normal amount, then it will result in hyperkalemia. Potassium will rise in the plasma. In the blood stream, the potassium will rise. Remember, so these potassium sparing diuretics, they have the opposite effect. They result in hyperkalemia. So the other diuretics, loop diuretics and thiazides, they were causing potassium to be excreted excessively into the urine, resulting in hypokalemia. So we had these potassium sparing diuretics. They are acting in the collecting duct, in the principal cell lining the collecting duct. They block the ENaC, but they may result in hyperkalemia because this principal cell is unable to excrete the potassium normally, secrete the potassium and excrete the potassium normally. So that's these are the diuretics, and that's how they can cause either hypo or hyperkalemias. And acid-base balance is another factor that can regulate the potassium secretion and excretion. Acute metabolic acidosis. Now, if there is acute metabolic acidosis, remember acid-base balance has a dual effect and it depends on the timeline. If it's an acute acid-base disturbance, potassium levels are changing in one direction. If it's a chronic metabolic acidosis, the potassium levels change in the other direction. Let's see how. If there is acute metabolic acidosis, then acidosis reduces the potassium secretion. Remember this. Acidosis, it reduces the activity of sodium potassium pump. So, this is a collecting duct and here is the blood vessel, and now there is acute metabolic acidosis. So, H plus has increased in the plasma. It will inhibit the sodium potassium pump activity. And because the sodium potassium pump activity is inhibited, now this is acidosis, H plus levels have increased. So, sodium potassium pump activity in the basolateral membrane, it's inhibited. That means what? That means potassium cannot be secreted from the blood into the cell, and therefore, and the other thing is potassium permeability of the apical membrane also is reduced. So, potassium cannot be excreted out in acute metabolic acidosis, and this will result in hyperkalemia. So, remember, acidosis, by inhibiting the sodium potassium pump, it increases the potassium levels in the plasma. It causes hyperkalemia. This is quite different to what we said in the beginning. I know that was related to the uptake by cells, and this is when this is the action in the kidney. So, if there is acidosis, yes, acidosis, it's not a contrary actually. What I am saying is mechanism is different. It's not contrary to what we said. H plus increases in the plasma, that means potassium also increases. Hyperkalemia, because H plus acute acidosis inhibits the sodium potassium pump. Chronic acidosis has an opposite effect. Chronic acidosis will enhance the potassium excretion. So that will result in hypokalemia. By decreasing, look, if there is a chronic acidosis, you know what happens? In chronic acidosis, there is decreased reabsorption of sodium chloride by the previous segments of the nephron in the loop of Henle. Sodium chloride reabsorption in the loop of Henle or in the DCT is decreased. So what will be the result in chronic metabolic acidosis? Decreased reabsorption of sodium and chloride. So sodium chloride remains high in the tubular fluids. Therefore, water also remains high in the tubular fluids. And we know what is the result. If the urine volume is higher, or the rate of tubular fluids is higher, or the volume of tubular fluids, I mean to say, is high sodium chloride and water in the tubular fluids, so rate of flow of tubular fluids increases. That means we have seen the cilia mechanism, and therefore collecting duct principal cell will secrete more and more potassium. Potassium will be excreted into the urine in more amount. So it will result in hypokalemia. So please remember, acute metabolic acidosis inhibits the sodium potassium pump. So potassium cannot go from blood into the principal cell, and therefore from there into the urine. Potassium levels rise. So acute metabolic acidosis, hyperkalemia. Chronic metabolic acidosis, something else. It prevents the sodium chloride reabsorption by the previous segments of the nephron. So sodium and chloride is high in the tubular fluids, and water, of course, because sodium is higher, water is also high, and therefore rate of flow of tubular fluids increases in chronic metabolic acidosis. And if that rate increases, we know already what happens. Potassium secretion increases, potassium excretion increases. So chronic metabolic acidosis, excess potassium excretion into the urine, resulting in hypokalemia. Quite interesting and fascinating topic, isn't it? Acute metabolic acidosis, some other effect. Chronic, some other effect. So that was the summary of potassium balance. Now finally I will discuss about the applied physiology. Quickly, let's go through this. We have already discussed some of these parts, have already been discussed. So let's see. Hypokalemia. Let me just summarize first. Potassium, normal level in the plasma, 4 milliequivalents per liter. Less than 3.5, and I have already mentioned it, that it should be tightly regulated, the potassium in the plasma. So less than 3.5, hypokalemia. More than 5 milliequivalents per liter in the plasma, hyperkalemia. And both are dangerous, particularly from the point of view of cardiac arrhythmias. So hypokalemia, when would that happen? You see, we've said potassium loss into the urine, potassium loss from the body, rather I would say, occurs by three routes: kidneys, GIT, that is in the feces, and sweat. So when hypokalemia is possibility, kidneys, first route, if there are diuretics given, or there are renal tubular disorders that are happening. Diuretics, I have already mentioned the mechanism. They increase the rate of flow of tubular fluids. Renal tubular disorders, there is a disorder called as Gitelman's syndrome. Gitelman's syndrome. What is the syndrome? There is a genetic defect in that transporter in the DCT. Look, this is a loop of Henle, and in the DCT I already told you there is a transporter which is called as NCC transporter, sodium chloride co-transporter. There is a genetic defect in this transporter, NCC transporter. So what will be the result? Sodium and chloride could not be reabsorbed from the DCT. So more sodium and more chloride reaching the collecting duct near the principal cells with more water, and therefore increase rate of flow of tubular fluids. That means more potassium secreted, more potassium lost out into the urine. Hypokalemia in Gentleman syndrome. So these are or hyperaldosteronism. You know, if there is excess aldosterone, it will reabsorb sodium and secrete and excrete the potassium. GIT, severe diarrhea, loss of potassium into the feces. Skin, strenuous exercise in hot and humid conditions, so loss of potassium can increase. Extensive burns also, there is a loss of transudate fluid with lot of potassium lost into that fluid. So one more, just last point, hypokalemia can occur even without changing the total body potassium. Okay, body's total potassium balance can remain normal and yet there can be hypokalemia. Right now I told you the mechanisms in which potassium is lost from the ECF and it can disturb the whole body potassium, but otherwise also net loss of potassium is not happening and still there is hypokalemia. That also is a possibility. Alkalosis, catecholamine surge, insulin administration in the diabetic ketoacidosis. We have seen this, that potassium is just being pushed from ECF into the cells, from the plasma into the cells. So plasma potassium is decreasing, cellular potassium is increasing. There is no net potassium loss from the body. Look, the conditions that I told you just now, like diuretics and hyperaldosteronism, there was net potassium loss into the urine, net potassium lost out of the body, resulting in hypokalemia. But now what I am saying, the conditions that I am mentioning, there is no net potassium loss out of the body, but still there can be hypokalemia. How? We have seen this a number of times now. This is a blood vessel, this is a cell. If something is pushing the potassium from blood vessel into the cell, net loss of potassium is not happening from the body. Just potassium is decreasing in the plasma. So these are the conditions which I mentioned just now. Alkalosis, catecholamine surge, insulin administration in diabetic ketoacidosis, they will all push the potassium. So remember this, whenever you are giving insulin in the conditions like diabetic ketoacidosis, don't forget to administer potassium as well. Replenish the potassium. Then reduced dietary intake or reduced absorption of potassium from the gut. You know, there is an interesting condition. It is referred to as pica. That's how it's pronounced pica. When some persons may have the tendency to eat clay, they have the propensity to eat different substances which are not eatable normally, but clay, some persons they eat clay, and this manifestation is called as pica. What happens is, if they eat clay, then that clay prevents the potassium absorption from the digestive tract. This clay will go into the gut and it will prevent the potassium absorption from the gut. So that can also cause hypokalemia. Whereas hyperkalemia on the other hand, pseudo hyperkalemia, I already told you, high laboratory value of potassium, but it's pseudo, it's not real, because there is no real injury to the cells, there is no tissue trauma as such. Just while you are withdrawing blood, while you are handling blood sample or blood, there was damage to the RBCs and that has caused this. Or as I mentioned, rhabdomyolysis. Myo is muscle, rhabdomyolysis. Well, the first I mentioned pseudo hyperkalemia. Now I am mentioning the real hyperkalemia. Tumor lysis syndrome, rhabdomyolysis, crushing injuries. Suppose there was an accident and there was crushing injury, skeletal muscles have been crushed, musculoskeletal system has been crushed. So that potassium from the cells comes massively into the circulation, causing hyperkalemia. So that's that. Digitalis, beta blockers, we have already mentioned this. They can cause hyperkalemia. Digitalis, as I mentioned, it's a drug that is given in cardiac failure, and it gets bound to the sodium potassium pump where potassium is expected to bind, and therefore potassium and digitalis, they compete with each other for binding. Now all this is out of scope for this particular video. We will stick to the potassium levels. Finally, both hypo and hyperkalemia result in ECG changes in arrhythmias. In fact, let me just say and end the topic here. That is, plasma potassium levels. If you go on to measure it may take a longer time for the values to be sent back from the laboratory. Laboratory may take a longer time to report the plasma potassium levels, whether it's hypo or hyperkalemia. But if you instantly record ECG, the ECG changes will instantly tell you about hypo or hyperkalemia. Remember this, therefore ECG is very important in that aspect, recording the ECG. So ECG changes with potassium we will discuss with some other video in CVS and ECG. ECG I intend to take as a separate topic. In that we will discuss it. But that's all for this topic. Remember, potassium is very, very valuable, important ion, and it has to be maintained very narrowly. Otherwise, it can play havoc with the system's excitable cells, acid-base balance, and so on and so forth. So that was in a nutshell the potassium homeostasis.